an epilepsy center is a really important component of care for anybody with epilepsy whose seizures are not well controlled, or people who maybe are going through a sensitive period of time like pregnancy. And that's because there's just more options both for therapeutics, diagnostics, and support. I would say one of my favorite things, and I think that you would agree with this, that's happened in the last few years is our relationships with neurologists around New York City and kind of the tri-state area, and people that have been working with their patients, but their patients are still having seizures, and they send them to us so that we can take a deeper dive. And we really love to collaborate with those neurologists who know their patients best. It's one of the most rewarding experiences, that kind of collaboration where we, share our knowledge about the patient and really try to take them to the next level in terms of their quality of life.
Many referrals come from out of the tri-state area, and it doesn't mean that that neurologist who works with us to help the patient loses the patient. Of course, those patients return back home across many states, and we are able in this era of Zoom calls and telemedicine to be able to continue to support that patient's care and that neurologist's management of the patient from a distance. I think really makes this program special and has benefited us tremendously is not only the resources that we have to help the patients from start to finish, but the scientific work that's being done alongside us to help advance our care. There are still many unknowns in epilepsy, and we are partnered with some of the most amazing neuroscientists the world knows to be able to get better information, to get better treatment strategies for the patients, and understand what we're doing right when things go really well.
The referrals for epilepsy surgery are really, really low, and we're not offering as many patients as we should the opportunity to look into some more advanced therapeutics. The biggest hurdle is the patient's own fear about the process, that they just don't want to have surgery. And what we sometimes try to communicate is that the seizures themselves are so much more dangerous than any surgical intervention, that living with uncontrolled seizures is a very risky business.
By the time a patient gets referred to the surgeon, they've been living with epilepsy for a while and have sort of come to accept that this is their fate. But one of the things that makes our group so special is the ability to identify the fact that, no, you don't have to just continue to put up with this. There are options available. And if you can overcome the fear and dispel some of the myths about, let's say, a surgical intervention like stereo EEG, where we're evaluating the brain's electricity from the inside, or the treatments that we're using to stop the seizures, yes, they are infinitely safer than a lifetime of suffering from epilepsy. The specific interventions, we divide them into two categories, the diagnostic categories and then the therapeutic or the treatment categories. In the diagnostic category, we've kind of talked about in that test of stereo EEG. We're doing electrical measurements on the inside of the brain, sometimes in some of the deeper structures that can control and modulate seizures. And then the therapeutic options are divided into some of the ones that have been around for 150 years, such as identifying a spot that's causing the seizure and getting rid of it. We call these ablative strategies. And then another strategy is to try to modulate the brain's activity in a way that controls seizures, that basically trains the brain not to have these abnormal electrical impulses that cause seizures. The neuromodulatory strategies that we use here in the Mount Sinai Health System are the age-old strategy that we've had since the 90s called vagus nerve stimulation, or VNS, where a little coil is wrapped around the nerve here in the neck called the vagus nerve that can then send electrical impulses to the brain to help calm the brain and in affect seizure control in a positive way in some patients. We have a device that's relatively new, now on the order of about 10 years since it was FDA approved, called the responsive neurostimulator. And that is something that basically acts like a defibrillator, a pacemaker for the brain, something that sees when the brain is going to go into a harmful electrical pattern that's going to lead to a seizure, and then deliver a little bit of electricity to that area to calm it down. And that's what I'm talking about when I say that we're able to, over time, train the brain circuits away from causing seizures in these patients. I think this is a very appealing strategy from the perspective of a parent. If I'm thinking about strategy for stopping epilepsy for my child in the long term, it's certainly better than having to get rid of a part of the brain. And it certainly is appealing because it's delivering regular therapy on a daily basis that seems to work better and better over time.
One of my patients who has the device just had a seizure, and we're looking at what the seizure looks like and turning the device on today. And him and his parents were like, well, what will the side effects be when this device is turned on? And I was like, there will be no side effects. It's completely free of side effects. And we tested it in the office and there was no side effects. And that's one of the differences compared to the high doses of medication that we sometimes use, is that it's actually like really, really well tolerated. We really believe in having every single available tool in our toolbox and individually identifying, evaluating patients to see what would work best or what combination would work best.
So when a neurologist makes the referral, I will make certain to get my own neurologists like Dr. Marcuse involved, because we have to have a thorough look at everything that has been done and see what else we need to do in the evaluation. The main points of the evaluation are the video EEG, the electrical study of the brain, and then an anatomical study of the brain in the form of the MRI. And these MRIs tend to be a little bit specialized because they have to be really fine-tuned to be able to look at every millimeter of the brain, sometimes allowing us to find subtle wiring abnormalities that we can see in the form of these things called dysplasias that can lead to seizures. And then we have a team of neuropsychologists that work with us that give us an objective measure of the impact that epilepsy is having on a person's memory, mood, cognitive skills. That is really a critical piece in the workup. And once those data points are together, then we generally are able to sit down and have a conversation about what the group would recommend as the best option for the patient.
Another part of the work that is so fulfilling is to get together every single week and go over cases in fine detail as a group and share our knowledge. 2 groups of clinical trials that we're doing right now that are more on the medication side. Jenna Yu, one of our epilepsy doctors, runs some clinical trials for new medicines that we're testing here at Mount Sinai. And we're also testing whether or not we can use IV ketamine to help people with refractory seizures. And that trial means that somebody would come in and get 6 doses of ketamine over 2 weeks to see if it helps them with their epilepsy and also with their mood.
And we have several clinical trials that are going on here in terms of the surgical aspects of epilepsy. They mostly focus around the use of the responsive neurostimulator, the RNS device. And one of them is to try to tackle one of the most difficult epilepsies around called Lennox-Gastaut syndrome. And there are a couple of other collaborative projects that we're working with other centers around the United States to try to come up with faster treatment strategies to make seizure control better, particularly in younger patients, adolescents that could benefit from this technology. And so we're getting tons and tons of data every day from these devices and from the recordings that we're doing, and we're able to put these to great use to forward the field. The recovery from surgery is actually pretty straightforward. The follow-up, however, is something that goes on for a long time, and we become a part of your family, and you got to keep coming back and seeing us if you're our patient.
I would say for patients that have gone through the surgical process, often after surgery, their primary neurologist will do some of the follow-up. It also depends on if the referring doctor was an epilepsy doctor. If someone has the responsive neurostimulator in place, a lot of times their home doctor will do the programming. It really just depends. And usually after epilepsy surgery, if we think that the area that caused the seizures is fully removed, people can come off their medicine slowly after 6 months, but very, very slowly. And we do expect people to stay on their medicines for at least 6 months.
The fact to underscore that epilepsy is far more invasive and far more harmful to a patient and to their family's well-being than these interventions that we've talked about and the modern approach to epilepsy surgery. All of these things together with the neuromodulatory strategies that we have now really are paving the way to a much, much brighter future for the epilepsy patient. And I know that Lara and I are both like-minded in this, as is our whole program here, that this message needs to get out.
When I'm thinking about people with epilepsy and their doctors and the people that love them, that I want people to raise their expectations for their life. Like, I want people with epilepsy to be able to have intimate relationships, to have children if they want to have children, and to not have children if they don't want to have children, to have work that is meaningful for them, to not feel overly sedated with medication, and to not just accept a life that isn't as good as they want it to be. And the changes and the intervention may be medication changes. It may be the ketogenic diet. It might be the responsive neurostimulator. But it feels very important to me that we raise expectations. I take care of a lot of people that their prior doctor, maybe it was their primary care doctor, was like, well, it's just a seizure a month. And I want to say there's no such thing. So if it's a seizure a month, it's time to really talk more and see if we can figure out some more solutions. And the whole picture really matters, what people are really doing with their life. And it's really about raising that game. That is the thing that I'm most interested in. And one of the ways to do it is to get the seizures under control.